the year. I am Altiti Saida Sadiq. This is GTV Breakfast. It's your favorite way to wake up. Let us know what you'll be doing the entire week. Our WhatsApp number is active on 055 556 1034. Our social media handles are active as well at GTV Ghana. Wherever you are in the world, you can watch us digitally, also on DSTV channel 278. We're going to be in the BFS clinic this morning, but there's lots more that you look forward to on the 4 hours that will be keeping you company this Monday morning. Keloids are raised as scars that can be challenging to treat and may require a combination of therapies for effective management. Now, while prevention is not always possible, early intervention with pressure therapy for existing keloids, dermatologists often recommend multimodal approaches such as laser therapy, cryotherapy, or other surgical excision combined with adjuvant treatment to minimize the recurrence. All of this, we're going to do science. We're going to break it down. And to assist us is Dr. Kofi Ansabrefo, who is the founder of Skin Foundation Africa, West Africa representative of the ISD. Dr. Brefo, good morning.
Good morning.
Welcome back to the table.
Thanks for having me.
How is the match going for you?
So as now, let's see how it goes.
That's your match.
Let's see how it goes.
It's how the league will end the way Arsenal would. But Arsenal looks like a safe team to support for now. Yeah, it looks like they are in a comfortable lead.
Exactly.
Let's just hope that it stays that way, because the City and Man U are on your heels. But keloids and pumbs, what is it? Are they one and the same? Are they different?
So good morning once again to your viewers. So keloids, we say it's an enemy of the darker skin. And we say this because it's very common, or it tends to be common in skin of color. Yes, there are some reasons. Keloids basically means excessive, scar formation. When you have an injury, or when you have a cut, we is supposed to heal. So wound healing is very important. However, in some people, you realize even after the wound is healed, it keeps on depositing collagen, and as if there is still some part of the wound that's supposed to heal, and it keeps on going for some time. With time, you realize that it grows in size. Anytime you feel itch or anytime you feel pain, what it means is it's getting bigger, it's expanding.
Is this the bump or the keloid?
So keloid is also a bump.
Oh, okay.
So bump just means any raised lesion on your skin.
Okay.
And but not all bumps are keloids.
Keloids, right.
Not all bumps are keloids.
Okay.
Keloids are it's very common, as I said, in skin of color, and keloid has a sibling called hypertrophic scar, which needs to be differentiated from keloids. So usually, as I said, if you have an injury, it's supposed to heal. Sometimes the healing or the scar formation is within the margins of where the injury occurred. And once that happens, we call it hypertrophic scar, because then what is happening is the scar starts getting thicker, but it's within the margin of where the original, where the wound is. But in keloids, it grows beyond the margin. So what you are seeing here, that's a very giant keloid. It tends to be very common on our trunk, or tension areas. So what you see started small. Usually, I'm sure there was some itchiness, there was some pain, and it kept on growing. Sometimes it can appear anywhere, but mostly you have the lower chin. People with what we call acne keloid. You also have the chest also appearing.
Is that the chest we're looking at?
So this is the chest we are looking at.
Oh, goodness.
This one, the patient had what we call shingles. So sometimes it also comes as a result of following an injury. So some people get chicken pox, for instance. So after healing, you realize the scar keeps on getting bigger or thicker.
Chicken pox.
Yeah.
Wow.
So yes, it can come out also secondary to infections. You can have inflammation, just inflammation, which tends to keloid formation. And so what you are seeing there, it's what we used to call it AKN, acne keloidalis nucleae. But now the name has changed. Now we call it, FKN.
Okay.
That's folliculitis keloidalis nucleae. And this is very common in us, especially when it comes from the hair follicle. So people who are prone to keloids, what happens is once you start getting FKN, there is a risk of, if it's not well treated, there's a risk of it becoming or growing to get bigger.
Is this susceptible at the back of the neck, like the head area? Because it looks like we see that quite often.
So that's why it's called the FKN. That's the nucleae. Nucleae just means neck. So it tends to be very common at the back of our neck. And people, once it starts, people use all sort of things. This one, for instance, if initially you feel some itchiness, with time, sometimes you even feel or you see, some discharge. And with time, if it's not treated well, you realize some of them starts getting, thicker. And if the person is prone to keloid formation, then what happens is it starts, growing. It grows and now becomes more pedunculated. It's more like it's... so what you are seeing there is not a keloid. So that's why we keep on saying not all bumps
are keloids.
So what you are seeing there is what we call fibroma, fibroepithelial polyp. And this, yes, it can arise on any part of your body.
That doesn't sound like a fibroid. Is it related?
It's related.
Okay.
So the tissues there are similar to it.
Oh.
So it's from a fibroepithelial a polyp. That's how it's called. And
what's the difference between that and keloids? Does it grow back too?
So the difference is very simple. So in this one, in terms of the keloid, you have more of these collagen, fibroblastic activities. But this one is different. This one is more like the epithelial cells that are multiplying. And we also have what we call we call it pyogenic granuloma. So the classic history is somebody has an injury, and so what you see there, it's genital warts.
Oh.
So this also tends to be very common, and people sometimes confuse this with keloids.
Oh my goodness!
So what you see is genital warts, an HPV, infection, and it's also an STI. It's also an STI. So these are
left untreated is what has generated into this.
So usually it starts slowly, then with time. So as you keep on, it starts multiplying. And that's the reason why we need to seek medical attention as soon as possible. Does it
have any relation also with shaving equipment, especially the ones that grow around the hair areas, like the back of the neck? Is that like you get it from the barbering salon or from your shaving?
So typically, this is what happens. It's very common. There's a divided school of thought. Some say if you shave to skin. So usually once you shave to skin, the new hair or the hair that is coming is supposed to, come out straight. But what happens is, especially in people with curly hair, so it starts growing and the tip of it starts irritating the skin because then the skin sees your hair as foreign. So it starts irritating it. Initially, the place is a bit itchy. With time, you start seeing all these bumps as the follicles get inflamed. Then sometimes you see, fluid or some discharge coming out. Sometimes it can actually be bloody. You see some blood coming out, and etc. So definitely...
Don't shave coli.
No. So definitely, we usually advise to avoid shaving to skin. And that's the primary, or that's how this whole thing comes about.
When it starts, what is the first aid that you should administer? At what point do you feel that you must go to the clinic? So
the sooner the better. So if you come, the treatment outcome is super. But if it starts getting thicker, and if you are prone to all these, keloid formation, then it goes on. So you realize it's multiplying in terms of numbers, it's all over. And in terms of size, it's also getting, bigger. And once it gets there, the treatment is not, just the topicals are not enough. Then there are times where we need to do, intralesional infiltration. We need to actually inject some steroid or some 5-fluorouracil to, keep on shrinking it.
Okay.
So the earlier you come, the better.
What about the ear area? There are people who cannot pierce their ears.
Yes. So, yes, in terms of keloid formation, earlobes also tends to be very common. Females getting, a second piercing or third piercing. So what you see there is not a keloid. What you see there is what we call pyogenic granuloma. So
sounds like granola, but it doesn't have anything to do with granola, I hope.
So what happened was she had a piercing not long ago. So the difference between this and keloids, with a history, this has a shorter, duration. So the classic history is that the person had a piercing maybe a few weeks, about 2 or 3 weeks later, and realized the whole area, a bump appearing at the site of the piercing. So what you see there, she actually has 2 of them, the bigger one up, and the lower one, you see a smaller one forming. So anytime we see this, we tell them, no, this is definitely not a keloid. Okay. This is pyogenic granuloma. And sometimes people, mistake this for keloid, and they inject steroid injections, and that's not the way to go.
Right. And why the ear though? Why?
So it tends to be common in tension areas.
You mentioned
tension areas. So some people, it appears on the earlobe, very common, and it also appears in kids as well. It has some genetic, disposition, because then you can have. So what you see here is the post-op surgery, or the post-op picture, following the one that the fibroma. So basically, we did what we call electroculture. Electroculture is more like just like a laser, but we are converting electrical energy to heat energy. So basically that is what happened there. This one, in terms of reoccurrence, is very low.
Okay.
So anytime you hear keloid, the most important thing is what to do to prevent reoccurrence.
And it's possible?
So yes, it's very possible. There are times when people they're a bit skeptical to even excise or cut the keloid. But if
that's
it's
what we
definitely
hear, that if you cut it will grow back. So traditionally they'll tell you to leave it on.
So I'm here to tell people, yes, if you cut without doing anything, definitely it's going to come back. So what you see there is a before and after picture.
Wow.
It had just happened. So you have this kind of keloid. Definitely, it's more pedunculated at the back of the ear. So this one you can easily excise. But in terms of preventing reoccurrence, a very important thing is, after you've done this, it has to be followed with intralesional or infiltration.
Okay.
So what you are doing, sometimes we do every 4-weekly infiltration. So the injection is to prevent it from coming back. So you inject some steroids. Sometimes we also do 5-fluorouracil. We do in a ratio 8:2, where you mix your steroids with 5-fluorouracil. And there are times when after excision, you need to follow up with radiotherapy.
Okay.
So all these are things that we do to prevent it from coming back.
You don't just finish the excision and then go to sleep, or after the operation.
Mostly that's what happens. So imagine you have a huge chunk of keloid, hanging on your neck or even your face. So once we excise it, yes, we do educate. There are times when you need to even patient need to sign an undertaking, because sometimes you do a very nice surgery only for the patient to return. That's if you're lucky, they will end up at your
facility again.
If not, you end up somewhere and say, oh, look, I removed it, some time back, and now it's coming back
again.
Yes.
What are we seeing on the lip?
So there should be the before picture. This is the after picture.
Okay.
So this one, the patient also had a bump on the lip.
Okay.
So that's what we call pyogenic granuloma. That's a giant one. So yes,
okay,
so this is the before picture that
if we
came.
can have the before.
Exactly. So this is a before picture that came.
Okay.
She had just a bite. Initially it was just a bite, and you realize that once you have an injury, we have blood vessels forming, capillaries. They push there. Okay. So sometimes you realize the capillaries are a lot. So what you are seeing there, if you cut or if it's a small pinch, you see lots of blood.
Oh my goodness.
It's highly vascularized, So in this case, what you do is you need to excise nicely. Then after the excision, you do what we call electroculture. So you are doing the two. You excise and you burn.
Is this a very painful procedure?
So it's done under anesthesia.
Okay.
So what you see, the first thing you do, you need to calm down the patient because of where it is. And secondly, I mean, it's
Very
done under
sensitive,
aseptic.
please.
Yes. And most importantly, you have a tiny needle. The diabetic, that's what they use to inject themselves. So we have the
Right.
insulin needle. Then what you just inject, or you put in your lidocaine or your anesthetic agent, which will numb the whole area. And once the area is numb, you take your time and you excise. After cutting, you just put your stitch nicely.
Nice.
And all you need to do is to keep on changing the dressing nicely.
Okay.
And it heals, and it doesn't come back.
Yeah, that looked nice. The after picture looked really pretty neatly done, Doc. What can you inject? Can you inject a keloid, or can you take medications to shrink it that it will just vanish out of nowhere?
So when it comes to keloid treatment, we need to follow. So first of all, it depends on the size of it. So the size, the site, very important, and also what you have. So if you have, let's say, a very tiny keloid, not pedunculated, it's flat, all you need to do is to do the 4-weekly, what's it called? Infiltration. You can use the steroids. You can do Kenalog. You can do Diprofos, Kerlock. But the side effect which you need to communicate to the patient is, once you keep doing, what can happen is it can suppress what we call the melanocytes. So usually if you do for some time, you realize where you injected becomes fairer. So the melanin there, or the melanocytes are suppressed.
Oh, the skin color.
The skin color there. So you realize it becomes a little, fairer than the other part of the skin.
Right.
And the good news is it's not permanent. So with time, the suppression, it blends nicely there.
Okay.
So definitely, yes, if it's small, depending on the side, you can do your infiltration. You can also do what we call cryotherapy. So cryo just means nitrogen gas, so you are freezing it. The advantage here is in terms of pain, very mild or very minimal pain. But in terms of reoccurrence, it still carries the same reoccurrence rate. So what you need to do is once you apply, or once you spray your nitrogen gas, usually we do every 2 weeks. So once you spray 24 to 72 hours, you realize some blisters starts forming, and there are times you need to repeat the freezing. And once you leave it, with time it comes off. Now the problem with the cryo is in terms of that suppression that the steroid would suppress the melanocytes. This one, that suppression is permanent. So cryotherapy, we wouldn't advise it on the face. So if a patient has, let's say, acne keloid, you don't advise cryotherapy being used on the face, because then what will happen is the light, the fairness that will happen will be permanent.
Absolutely.
So you don't want that. You can also do a laser. You can also do what we call 5-fluorouracil. You can do radiotherapy, and these you can also do electrocautery. So electrocautery is you literally burning the keloid.
Oh.
And if it's pedunculated, it's given very severe in terms of disfigurement and stuff, then you can excise it. However, it has to be followed with these preventive measures.
Absolutely. I think because you also mentioned earlier on about the blood and the ventricles, and that's why people feel like if you cut it, you may die. What is the death rate when it comes to excision?
So once it's been done, but in terms of death rate, there's no, complication
Data.
is almost, zero. Yes, depending on the size. So the huge one that you saw, the one on the
Chest.
trunk,
Okay.
obviously it has to be done under plastic surgeon guidance, because sometimes you need a skin or you need a flap to close it nicely. So this one, for instance, what will happen is you can't just cut it. You can't just cut. So there are times when you cut. And also another thing that leads to reoccurrence is in terms of tension. So you can excise the keloid. If there is too much tension there, what will happen is it can easily give. If not, the healing takes a longer time. And in terms of reoccurrence, it's also very high in tension areas. So as broad as this one, what will happen is if you remove it, no matter how you try to oppose, the skin together, the ends, what will happen is if you don't sometimes you don't get the ends opposing nicely. Even if you oppose it, there will be tension there.
Is it a graft, skin grafting?
Yes, so sometimes that's what is advisable. Once you cut, you wait for it to heal to some level, then you just do your grafting. Yeah.
Wow. It's interesting. What have you seen? We have to go, but what have you seen are the very interesting treatments that people have used to treat their bumps and keloids? And also, I do believe that I've seen that it's a low confidence situation. What are some of it? Yeah.
Yes, so keloids, I have seen a couple of them. I mean, especially with females. If a female has a keloid on the breast, mostly you don't see them early. You don't see them early. Or if it happens on the pelvic area, you don't see them early. And I keep on saying the earlier you come, I mean, the better in terms of the cosmetic outcome.
I mean, if you see a bump on your breast and there's breast cancer, you should be scared.
I had a female somewhere last year who, visited a 22-year-old. And it was that bad. It had affected the nipple. It had, gone inside, and it was terrible. So at that point, what's the most important thing to do is for the plastic people to, come in. So in terms of keloid, some local remedies, people use all sort of things. People, they tie with thread sometimes. I've seen a keloid that has become necrotic. It was tied. So all they are doing is they are cutting the blood supply to the area. And once that is done, yes, it may heal by secondary intention, but at the end of the day, it's still going to come back. And there are times when you can decide, or we even try the infiltrations to mask it or to reduce the size. So once you reduce the size, then you can easily remove it. Because there are times when they are huge. If you decide to cut, the tension there is too much. So all these are things that we need to do. And it's not only keloid. So we can also have what we call sebaceous cyst. Some people call it epidermoid cyst, and it presents like a boil, but it's not a boil. And the reason why we need to bring this to people's attention is people see and they still do infiltrations in that one. So that one, what is happening is you have like more like a boil, but it's not a boil. It has like a lining. The name is sebaceous cyst, but it doesn't come from the sebaceous gland. It comes from the follicle. Infundibulum part of the follicle. So yes, you have that one. We also have lipoma. So lipoma is accumulation of fat tissue. So you can have fat tissue being accumulated in your skin. And sometimes it runs in the family. Sometimes all you need to do is you just excise it nicely and you are good to go.
I think I've seen that in a male's testicles before. Is that it? Or lymphoma? One of them. I was part of this surgery project by Graft Foundation, and I saw the before and after was amazing. But yeah.
And any person who has had a previous history of keloid, let's say cesarean section, or you had an injury, what it means is there's a risk of you having, that risk still exists. So you need to, take care of yourself. Anytime you have a wound after it has healed, you need to follow up. Either you do, if it's that mild, there's no bump there, you can do your silicone sheet. You apply your silicone sheet. What you are doing is you are trying to prevent.
What's the silicone sheet?
So it's just like a plaster.
Okay.
So what you do is you apply on it. And sometimes you can do overnight, sometimes you can do throughout the whole day. And the whole idea is it helps, with the hypertrophic scars. Right. It also helps as an adjunct if it's a proper keloid, But as I said, depending on the size of the keloid. So the size will tell you exactly what to do in terms of the treatment.
Lots to unpack. How can anybody who has seen a bump right now, contact you? Reach out so that you help them prevent it from escalating to life-threatening or points.
So because it's a Heritage Month, what we are doing is, if you have a bump, or if you have a relative, you have a friend who has a bump, what we are doing is you can call this number, or you can send like a video of it. You can take a picture, you can send a video of it. You don't know what it is. We are going to give you free advice. So contact 0256 06 3807. So 0256 06 3807. Get in touch with us. You have genital warts, you have keloid, you have a bump, you have something that looks like a keloid. You don't know, you're not sure. Your own is a bit softer. You have something that looks like a boil. It has been there for years. You have all these bumps at the back of your scalp. Just contact us and we'll tell you exactly what to do.
Thank you so much, Dr. Kofi Ansah-Breffo is founder of Skin Foundation Africa, West Africa representative of the ISD. And, you can get your consultation. I've been getting my consultation from Doc Ed for my skin. And he says that not all bumps are keloid. So understand what the differences are and then see the specialist so that they help you determine what the treatment options are so that you can, have your confidence and have beautiful skin. Thank you so much, Doc, for doing this with us. Keloids and bumps, prevention, treatment, and care. To dila fila zangpa ben yi mor anang benane ka borna bang bolele nyele I chang a shipene Dr. Mbongo zongo number pa social media I chang GTV Ghana anto nyele ka menu di alizama zangpa anyenye fa kunta mangsham. I am out to decide us we're back with more on GTV Breakfast is Mother Thanks, so please still speak your mother tongue this Ghana month.